Hello and welcome to this online event looking at using digital technology to transform care pathways. I'm Joni Jabel, I'm a researcher in health policy at the King's Fund and I'm going to be chairing the event today. I'd like to start the session by thanking NHS South Central and West who have sponsored the event today, and we'd also like to thank the Digital Care Models Team Transformation Directorate at NHS England and NHS Improvement for their support for the event. We have a great panel of speakers today representing a whole range of perspectives, and I'm going to introduce speakers individually because the best information about who they are can be found in the speaker biographies. You should be able to access them in the video just below. We also have a really great audience for this event. We checked just before coming online and we have over 1,400 people signed up so far. And I've looked at the attendee list and there's a real range of people watching today from across different sectors, including charities, NHS commissioners and providers, private organisations, patient representatives and universities. So just to explain very briefly how this session will work. The online event is live and includes a panel discussion and then a live Q&A session. We'd like to invite you, the audience, to submit questions, and you should also be able to see a Slido box to the right of the video, which is where you can submit your questions and upvote questions others have asked. We'll aim to answer the most popular questions. We'll also be putting some poll questions to the audience. These will flash up at various points in the session to the right of the video. Please do try to take part in those. And finally, we also recommend you follow the conversation on Twitter using the hashtag KFOnline. We recommend you looking at the resource page on the left-hand side is a menu of series of options which you can navigate to the resource pages here. Just to introduce the discussion today, digital technology has already transformed how services are offered, accessed and used. Technology has enabled changes around flow of information, not only between patients and clinicians, but also amongst staff working in different parts of the system. That might help to ensure patients can access care in the right place at the right time. So we'll open up with a panel discussion, and I'm going to bring in individual panel members as we go through this. So the first question, in this session, we explore how some of the national strategy for virtual services and pathway redesign with a focus on virtual dermatology services through the lens of NHS England and Improvement's National Teledermatology Investment Programme. As with many health services, the COVID-19 pandemic increased pressure on dermatology services, creating an urgent need for significant potential to improve dermatology referral pathways with digital technology. To introduce the session, I'd like to firstly turn to Inara Khan. Inara is Deputy Director for Digital Elective Care, NHS England and Improvement. Inara, can you please provide some background to the national strategy for using digital technology to transform care pathways and our case study for today's session, NHSEI's Teledermatology Investment Programme?
Thanks, Joni, and yeah, massive thank you for having me here today, and to the CSU for all the work that we've done with them on this programme. So I think, you know, there's sort of two sides to the story. Obviously, as the pandemic hit, technology was seen as the sort of silver bullet for a lot of services to try and support people outside of hospitals, and also recognise that the waiting lists were continuing to get longer and longer. And you know, as we sort of start to come out of the pandemic, things have changed slightly. So although the national strategy was let's just try and support people as much as we can with technology and support clinicians and ensure that we're delivering good patient outcomes, we've come to a much more strategic place on that now. We're not in that reactive mode. So at present, the national strategy is where you do not need to turn up to a hospital appointment. You shouldn't have to. And actually, if you can and monitor your condition at home, or if you can take pictures or use other digital technology to support your care, then you should be able to do that. And this not only empowers patients and allows them to have more control over their own care and understanding of the impact of their own care, but it also reduces the burden on clinical services at a time where we've seen waiting lists the longest that they've ever been, people waiting 104 weeks or longer for their appointments, and again, the longest that those waiting lists have ever been, and for really crucial services like cancer 2-week wait referrals, just several hundred services across the country not meeting those targets that have been set. Although digital technology isn't the silver bullet, it is there to support services as they stand. So that's really what we're trying to do from a national perspective, and that's the rationale for the teledermatology programme. So we invested just over £5 million in teledermatology, recognising that about 1 in 4 people will visit their GP annually for a dermatology-related issue, and there are 3 million, and this is before the pandemic, 3 million dermatology outpatient appointments a year, with massive dermatologist shortages. I think we only had about 650 at last count. So there's huge pressure on these services, and actually there's some really good technology out there that can help and support people to get access to NHS services to support dermatology related conditions. So that's very much the background and the strategy at the moment.
Yeah, thank you, Anara. That's really helpful, and I think there's lots in there that will be picked up throughout the discussion now. And it'd be nice actually at this point. So NHSEI have worked closely with NHS South, Central and West to deliver and evaluate the programme. And today we're joined by Maxine Bowen-Hall, Programme Manager Digital NHS South, Central and West. Maxine, can you please explain how the national investment has supported regions to develop their virtual dermatology offers, and how different parts of the systems prioritise, implement and track different innovations to meet their local needs to improve outcomes?
Yeah, morning everyone. So the programme has not been prescriptive in how the regions used the investment for this programme. So some regions redesigned their pathway, their care pathway. Some purchased equipment such as dermatoscopes, and others actually used software to upload images to be able to engage from primary care to secondary care to have advice and guidance. So we weren't prescriptive in how any of the regions delivered their programmes of work. They know their population, they know what the pressures were on them in those areas. But what we have asked for is for feedback and understanding and engagement in 3 particular areas, so that we can learn from this. And the whole ethos of this programme is actually that we're learning from each other as we go along throughout the whole life cycle of the programme. So we have asked and worked with Anara and the team and the regions to build a set of case studies, and we'll hear from Tracy and James around some of those as we go on this morning. And so we built case studies with all the ICSs so we can understand the challenges, how they delivered their programmes and what they learned from that. We have supported them, as we've heard from Anara. Everyone is very time poor in this area, so the team have actually engaged, produced those case studies, just asked for sign off of the case studies to have the least amount of time used by those areas. We've also built a template to measure 5 different metrics, and we've built that for the regions. We've brought the data sources all together to look at the impact and the uptake on advice and guidance, appointments, referrals for this particular pathway, the impact on 2-week wait and 18-week referral to treatment. So we've brought all that together for the regions as well, built a template, asked them to validate that, and then we build a dashboard where we can look at each region, each ICS, see what the baseline was like, see the distance travel for the projects as they go through their delivery. And we also ask for the regions to come each month to a steering group, so that again we can learn from them, we can share progress on delivery plans, we can have a forum where people ask each other for support and advice on some of the challenges they've experienced, whether that's with the use of some of the equipment or if that's around some of the pathways that they've been developing, and just to share good practice as well. So we've brought those 3 areas together. Like I said, we've not been prescriptive on how they deliver their programs of work at all, but we just want to have some commonality in the feedback and the learning from one another.
And thank you, Maxine. Again, there's so much information in there, and I'm sure that we're going to get picked up with some of the questions about the kind of that national oversight, but also local agenda setting, which is a really interesting balance. If we move on, you've kind of already started to mention some of the impact, but what I'd quite like to go on is, now that we understand more about the programme, I'd like to think about the opportunities the funding has had to innovate clinical delivery and the impact on patients. And I'm delighted to be joined by 2 clinicians working in different parts of the system who've successfully applied for programme funding. So we have Dr. Tracy O'Shea, Dermatology Service Clinical Lead at SDS My Healthcare, and Dr. James Halpern, who's a consultant dermatologist and Clinical Director of Dermatology at Walsall Healthcare NHS Trust and Royal Wolverhampton NHS Trust. Thank you. Please, can you talk us through why you applied for the funding and what that's enabled you to do? If I can bring Tracy in first, if that's okay.
Hello, yes. I applied for the funding with SDS My Healthcare because the backlog, the long waiting times we're experiencing as a result of COVID, and also the opportunities that COVID actually allowed us to have with opening up the digital platform. So there's a long history of teledermatology and trying to find safe ways of producing and providing services, and there are lots and lots of clinical governance problems with that in the past. COVID actually took the stops off, and it has been the most amazingly transformational the thing to have happened to me in my experience in this area. So we wanted to pilot a scheme whereby we used initially healthcare assistants to take high quality digital images, both dermatoscopic images and gross pathology images, to then download directly into the patient record to enable a community dermatology service based predominantly amongst gypsies, GIPWA specialists, to help and to enable triage. And what we found quite quickly is that there are 2 needs. There's a very big need for the population who don't have access to digital technology, who are unable to send in photographs on the existing platforms. So PicSave, Consultant Connect, AccuRx, they were excellent tools for those who were able to use them, but a significant portion of the population weren't able to access those. And also then for lesions, actually the quality of images wasn't good enough on those pictures to enable any sort of meaningful assessment. So we used the money to buy basic equipment, a derm-like dermatoscope, a camera. You can also use iPads or other tools for this, even a phone that doesn't have a connection, doesn't have a data connection, just as a camera tool. And we started to offer services initially from one location where GPs could book directly patients in for lesions that they didn't think were suspicious but wanted reassurance on, or for patients where the clinical picture, we couldn't really get access to it. We then have started to extend this now to multiple hubs, because what we found is that the individual with the equipment is mobile, and that allows us to cover really quite a large population and to overcome the clinical governance issues, because these images are not being stored anywhere other than directly on the patient record.
Thank you, Tracy. There's a few follow-up questions I think that will come to definitely in the Q&A session, but I'd like to bring James in if I can now, just to discuss your experiences as well in terms of why you applied for the funding and what that's enabled you to do.
Thank you. I'm representing the Black Country Teledermatology project, and this is one of the more ambitious teledermatology projects in the country. It's not for an individual trust, it's actually for an entire ICO, and we're representing 4 acute trusts, each with 4 separate dermatology departments. but we're going for a unified teledermatology service, which will cover the entire population and some of the surrounding population. So we're covering 1.5 million patients over 200 GP practices. The reason we applied for it, similar to what Tracy has said, is just the sheer increase in demand. The main thing hospital departments are struggling with is a large increase in the 2-week wait fast-track cancer referrals. Here in the Black Country, our referral levels have doubled compared to pre-pandemic, but our conversion rate to a final diagnosis of cancer has halved. So we're getting a lot more patients being sent in with benign skin lesions, and we need a way to triage out those patients because all our services are just collapsing under this deluge of activity. We bid and were successful. We got £500,000 to introduce the teledermatology service. We then brought on a project manager and got a project board set up. And I think the most key thing we did was got very good primary care involvement with it. If primary care are going to engage with a project like this, they really need to be involved from the very beginning. The chair of our project is a GP, and we've got 3 GPs on the board and me as a single dermatology consultant. And I actually think that's the right way to do it. And also, surprisingly, we've got on really well, and we've had agreement. There was agreement between primary and secondary care when we were procuring both the software and the hardware for the rollout. And we're now on course to roll out in the next month or two. And we're just really looking forward to all the benefits, both for patients having care close to home and for less demand coming into secondary care.
Thank you, James. And again, I think there'll be lots of follow-up questions that will come through the Q&A session. But just to keep the panel on track, I just wanted to bring in Chris, if I can, at this moment. So with all of these case studies and experiences that we've heard of, it's vital that the patient is at the centre of any transformation in clinical services. And we have Chris McIlveen, who's a patient and public voice partner for NHS England's Transformation Director and sits in the National Teledermatology Investment Programme Steering Group. So from a patient perspective and seeing the rollout of the programme across different areas, what would you say with the programme has provided in terms of key benefits for patients? And are there any kind of key barriers that still need overcoming? So if I can bring Chris in at this moment.
Thanks, Yoni. Good afternoon, everybody. Delighted to have the opportunity to contribute to this discussion. As Johnny's mentioned, I've been involved in the steering group of the programme. I'm also heavily involved in the electronic referral service optimisation programme. So I've got quite a good bird's eye view of what's happening across the piece. From a patient perspective, there's absolutely no doubt that the application of this funding across the different regions has delivered significant benefits to patients who've been fortunate enough to experience their teledermatology services. And I think these benefits fall into a number of areas. Because as part of this investment, the use of the advice and guidance channel of ERS has been a key part of the process. This means that primary care clinicians have been able to have very meaningful dialogues with secondary care specialist colleagues about individual patient conditions, very often with the availability of high quality clinical images and blood tests, etc. And in many cases can reach a very rapid diagnosis and a treatment plan, which avoids the patient having to wait a long time for an outpatient appointment, which in many cases may prove to be completely unnecessary. So not only are we speeding up patient care, we are helping to unclog the massive national waiting list that we're all suffering from at the moment. Secondly, I think the use of dermatoscopes and the provision of high quality images has enabled much faster and more accurate diagnosis, and in particular, an area which is very close to my heart, and that's identification of potentially cancerous conditions in a timely manner that enables them to get on the fast track to the right treatment. And in many cases, this is enabling more effective patient management in one place, closer to home for the patient, because they can receive in some cases, all their treatment in a primary care setting, as opposed to having to go to a hospital, which might be a long way away from their home, difficult to access. So it's helping in that area too. And I think the final benefit is learning for GPs and healthcare professionals who are involved in this program. Because they're able to discuss patient conditions directly with specialist consultants, their level of expert knowledge is increasing in this area, and that can be used to benefit future patients in their care. In terms of key barriers, I'm not sure these are barriers as such, but there's certainly two areas of concern that I'd like to share. The first one, which is interestingly already popping up in the questions that are being asked, and that's the fact that the adoption of these services relies on the availability and the accessibility of the right level of digital technology, not only for patients, but also for GP practices. And we need to be very, very careful as we roll out these digital solutions that we're mindful of areas of digital poverty and exclusion, which still exist in many areas of the country. And we need to understand how those patients and practices can still benefit from these developments, whilst having that level of digital exclusion. And secondly, patient awareness and communication is absolutely vital. But then I would say that, although many patients are directly benefiting from the use of ERS advice and guidance, not just in this area, but in other areas too, many of them are totally unaware of what it means, and they're not included in the dialogue that takes place between clinicians. So my final point on this area would be that the patient needs to be at the centre of the communications, not just a CC on letters between clinicians. Thanks, Johnny.
Thanks, Chris. And it's really interesting and important point at the end there. If I can bring Inara in now, how does what you've heard fit with the impact you've seen at the national level?
So the areas that we've invested in, on average, we've seen an over 30% increase in advice and guidance. And I think that number really speaks for itself. So, and I hope Tracy can speak to this in a bit more detail around the actual impact. But it means that we are empowering GPs to have those conversations through the technology. And it means, as Chris has set out, that we're not having those follow-on appointments in secondary care unless they are needed. And I think one of the things that in terms of impact is really important for me is almost that this is seamless for the patient. So that patient might not know that they've been subject to advice and guidance because that picture's been taken, but ultimately their care is more tailored to them and their lifestyle, because we can manage whatever that condition is within dermatology, either within primary care or discharge them with the right treatment as soon as possible. And I think there's, especially around things like 2-week wait referrals, there's a lot around reducing anxiety for patients as well. And I think, some of the case studies and the feedback that we're getting is that this is enabling patients to reduce that anxiety. I can't imagine what it must be like to have a mole that you're concerned about, and if you're told that you're not going to have an appointment in secondary care for what could be months, that would be really difficult. And what we don't want to do, and we're not here to do, is to push people to feel like they have to pursue private care when this should be available on the NHS. So we have seen an impact in terms of the metrics that Maxine set out that we are measuring, but it's not just about those hard measures. It is also very much about the impact on the patient personally, which we are hopefully capturing through our case studies.
Thank you, Inara. And just a really quick follow-up question there. You mentioned at the beginning about the impact on GPs potentially around learning and developing their own expertise in these areas. Would you say kind of more generally any other kind of workforce impacts, particularly given that in some case studies it's a requirement, this kind of the system is based on having more people doing things in community settings and learning how to use that tech themselves to be able to deliver that to the patient? Is that something that's come up, or how has that kind of been?
It certainly has, and I think the model that referring to Tracy again, because the model that I think that you are implementing, and we're really seeing the development of people's skill sets, such as healthcare assistants and others. So this isn't just about people doing something different, but it's also about developing the skill sets that we have in line with digital technology, and broadening those roles, and hopefully, you know, making NHS staff feel like they're not just delivering more of an impact, but they're actually at the forefront of some of that innovation as well, which, you know, is very reassuring for them. But I hope that Tracy can add a bit more on that.
Tracy, would you like to come?
Yeah, certainly. No, I absolutely agree with what Inara says. In general practice, you cover such a huge range of conditions, all patient groups, everything that comes through the door, and very often what you need is reassurance. So most GPs, I think, have a very good idea of whether a lesion is sinister and what a real 2-week wake is. But there is also a group of lesions in between that the GP thinks, I don't think it's a cancer, but I'm not certain. And prior to, you know, digital technology, they had 2 choices. They had 2-week wait, or they had routine referral that someone would wait 6 months. And frankly, they weren't prepared to wait that long. So I think things like the teledermatology services, I hope in the longer term will start to reduce 2-week wait referrals, because they provide an opportunity for GPs and other healthcare staff to be reassured, you know, realistically and accurately that actually this lesion is not sinister and that it is safe to wait. So I think it's very, very useful in that way. The other thing in primary care is you need a pragmatic solution. You know, you have, as I say, the whole range of patients, and you have people with little or no access to technology. So being able to provide something in the community setting where most people are used to going to, they're used to accessing their general practice. It isn't as complicated or as expensive or as time consuming as going to a hospital. And if we can utilize and one of our great strengths is that there are thousands of community primary care services out there. If we can use those as the locations to gather the high quality information, then whether you have specialist GPs with special interests like myself, or you have ERS communications with the consultants, you just can hopefully speed up that transit of the patient's cases through, but also triage more effectively. So really for us, the impact on triage has been huge with this. And there are some patients still that you can't make a decision based on the pictures, obviously, but that's fine. We anticipate that and we bring those patients in for face-to-face.
Thank you. Thanks, Inara. Thanks, Tracy, James, Chris, everyone who's responded there. Just moving on, it sounds like there's been some excellent progress being made. And I think myself and the audience would like to understand what's next for the programme, about the case studies that we've heard today, but also about the experiences and lessons from dermatology and what they offer to wider learning across the NHS to continue empowering patients, supporting clinicians to create patient-centred care, which lead to improved health outcomes. So if I can, I may just bring you in individually. If I can begin with Maxine, perhaps, to talk about the project in particular, including impact and evaluation.
So from a programme point of view, as I've said, this is all about learning from one another and looking at all the various different models that are being implemented across the country. So during April and May, we are going to undertake a full impact and evaluation of the whole programme. So that will be looking at the data and the metrics, but as Inara said, you take a common sense approach there, because there are seasonal differences we can take into account at times. So it's really important that we have the feedback from the regions and understand what they've benefited from and what the impact's been there. But also we want to look at all the various different models. There's a range of them, from some of the very small projects that have started, from the purchase of dermatoscopes for 6 GP practices and the learning and pilot and feedback from there, which is now going to be rolled out to around 230 GP practices, or what we've heard from Tracy and James as well today. There's been a number of different models as well to look at the inequality of access across different areas as well. So where in one of the areas in London where there is a real shortage of dermatologists, they've used their medical photographers who take images, upload those to a secure platform, and they've been able to virtually pool those dermatologists, those very scarce resources together to give resilience in the system and to give more access to patients across that whole system. And again, heard the bringing of primary care networks together to do very much the same thing, to enhance the access for patients in different areas. So we're going to look at all that, bring all that together. Obviously as well, it's really important that we understand what the patient experience has been, but as Inara said, quite often when there's a digital aspect included, that's quite seamless, you may not be aware of it. But some of the regions have done very targeted communications to some of the patient cohorts to explain to them that though they might not see this, this is what's now happening as part of their patient journey. So we want to bring all of that together, and we're also mindful that although our programme has a certain time frame, that the regions are not stopping their work. So we're really keen to understand what they're going to move forward with their next steps and what's really worked for them as well, and continue that forum so all the regions and everyone can come together in the systems to share their learning. So that's what we are moving to over April and May.
Thank you, Maxine. That sounds like a really powerful outcome, actually, that continuation of sharing of information and learning. So that sounds really positive. In terms of the individual case studies, can I ask the same question? And I'll come to James first, if that's okay.
We very much see that teledermatology is the first step in wider system change. The move away from trusts competing against each other to working together for the benefits of our patients. And we're seeing it as really the linchpin in integrating the 4 dermatology services within our region. We want to make it as simple as possible for our GPs, rather than them having to decide, is this advice and guidance, is it routine, is it urgent, is it 2-week wait? There'll just be a single point of access. They can put all their queries to it. They'll be looked at the same day by a consultant dermatologist, and we can share that burden across the 4 trusts, so one trust doesn't have too much activity to do. And then we get the patient to the right place first time. And that is what's absolutely key, because even within secondary care, we have subspecialist clinics. Does the patient with a skin cancer need to go to see a dermatologist or a plastic surgeon? And we want to make the pathway as short as possible. Further on in the teledermatology, we're looking at things like super clinics, where we're combining same-day surgery for these triage patients to meet the 28-day faster diagnosis standard, to get the patients, we've seen them by telederm, we know they've got a cancer, so they come in, they see us, they get operated on straight away. In the future, we may even want to miss out that step and get patients with cancer directly onto a theatre list by giving them sufficient information that they're happy to do that. That would have to be for selected patient groups, but we've got to be ambitious. It's the only way we're going to get on top of all these demands we've got.
Thank you, James. And can I come to Tracy, please, with the same question?
My view is that you get buy-in from staff and from clinical healthcare in the community if they're confident that the quality of advice or assessment that you do is high, and also that it's timely. So GPs, advanced nurse practitioners, everybody, if you have a worried patient, you want to be able to reassure them that you will get an answer for them quickly. And I think that's where actually we've had excellent buy-in, because we either can get the GP to take a picture, or we can send the person to get a high quality dermoscopic image if need be. Again, as James says, the beauty of that is it can be triaged the same day, or within a couple of days, and then advice can be given to the GP. And it isn't just about lesions. Very often there are rashes, there are various things that the GP isn't confident about. We can undertake first line management strategies, request blood tests, do whatever, set a management plan in place. or we can say to GP, this lesion does look sinister, we have done a 2-week referral for you, or we want to bring this person in to take a closer look. So the speed of response is the first thing to ensure that these services are well used, and the quality of the response as well, being reliable. And that's where integration with the hospital staff, with the consultants, is a vital part of that.
Thank you. Thanks, Tracy. And bringing into the picture the patient voice, from Chris, what would you say would still need to be addressed and how we can apply it to other areas?
Okay, thanks, Johnny. I mean, for me, as Maxine's already mentioned, we've had some real innovation as a result of what the regions have done with this funding, and I think it's important that we collect that learning together, principally via the case studies that are going to be produced, and that we draw out the key results, and that can enable us to understand what is the best of breed solution, which can then be articulated and scaled out and then rolled out across other regions to benefit even more patients. I am a great believer in reuse and not reinventing the wheel where it's not required. So if someone, as I'm sure they have developed the best solution for this particular area of medicine, then we should be understanding what that is and getting that rolled out across the piece. In terms of patient communication that I've already alluded to, there is a major piece of work within the ERS programme, which is now called My Plan Care, which is basically all about digitalising patient communication via the NHS app, and that really needs to continue to progress hand in hand with that, so that we address the needs to keep the patient in the conversation. And on ERS in general, I think one of the things that's potentially impeding progress nationally is the fact that ERS has actually got 3 channels that you can still use. There's the old choose and book service, which colloquially known as choose and forget. That's still in use across many areas. There's the referral assessment service, and then there's the advice and guidance, or advice and referral, as it's been rechristened. And the wider optimization program needs to address the strategic need to standardize on the advice and referral channel, to make that technology available to as many regions and RCSs as possible, so that we can maximize the benefits. And thirdly, I think there needs to be an understanding of how we can train and educate a wider pool of healthcare professionals, perhaps allied health professionals, to be able to use these services effectively, take some of the burden off, hard work GPs. But in doing that, we need to ensure that the appropriate governance is in place to deliver the standard of service that's required. Thank you.
Thanks, Chris. And just finally, if I can bring in Inara, who, if I can ask you about the national picture and the learning for other clinical areas as well, that would be great.
Yeah, so in addition to dermatology, we're doing work across musculoskeletal conditions and gastroenterology this year, with a view to expand that to respiratory, neurology, and some cancer services next year. And the learning has been massive. I mean, obviously the technology is not always the same, so it's not going to be like for like. But there is a lot around how we support implementation and what works and what doesn't. And I think, as Maxine said earlier, we're not here as a national organisation to say this is the technology, implement this. What we're here to say is these are the outcomes that we think you need to focus on in line with the national picture. We do sort of signpost to examples of good technology, and there's the digital playbooks. There's a specific dermatology one that help people along the way where they don't know where to sort of start with that technology. But it's really important for us to allow, whether it's regions or integrated care systems or trusts and providers and others, to make informed decisions about the types of technology that work for their population, so based on a population health approach. And I think there have been several questions around how do we ensure that, that digital inclusion is part of this conversation. So we're certainly not mandating the technology, but we're saying these are the outcomes and here's some examples of technology. And secondly, that work with the pathways as they exist, and the systems as they already exist. So there is no point trying to integrate a piece of technology with a system that you already have that's just, it's going to take years and years of development work to be able to do that. So yeah, from our perspective, there's a lot of learning from this programme, I suppose around the methodology of supporting digital transformation at a local level, and very much so around the sharing and learning that the CSU have really supported us with sort of pulling together. And I think there's almost policy recommendations that will come out of this programme of work around things like workforce, around how teledermatology supports 2-week wait cancer referrals and the faster diagnosis standards. So the impact of the programme is one on on other specialties, absolutely, but two on national policy as well.
Yeah. Thank you. I think there's just so much that we've heard throughout the panel discussion, and I know that we've had so many questions coming into the panel. So just to thank you all there for the panel discussion, and I know that some of the questions that we're going to come in now from the audience are touching on some of the things that they've heard, and kind of just going into a bit more detail. So at this point, I'd just like to go into that Q&A session. I know that there's lots and lots of questions. I've got various members and colleagues helping me out field these questions. I know that we're looking at these on Slido, and we are upvoting various questions. So the first question that I've got to the panel is, we're seeing more suggestions for digital innovations, either as innovations or adopting other innovations, but trusts are struggling to support these at pace. How can we ensure that we don't stifle potential digital innovators due to capacity and funding issues to keep that momentum going? And if I can, Inara, if I can bring you back in on that question first, and then if there's anyone else on the panel who wants to answer that as well.
Yeah, so I think that's a really important question, because we're not just here to solve the issues that the NHS is facing today, but also sort of think in terms of the horizon and what's coming up. And we absolutely have a role to support not just tried and tested technologies, but ones that are going to meet the needs of the NHS in the future. So I mean, there's a couple of ways that nationally we have to operate to make sure that products that we do support or that are purchased locally are in line with the relevant safety and clinical and other standards. So the first is that any digital innovators working in the health space should go and have a look at the DTAC process, which is the process that pulls together all the existing standards around digital technology. And that's not a way to stifle digital innovation, but that is very much a way to make sure that it's safe for both patients and clinicians. And secondly, the academic health science networks are the best friends for all digital innovators up and down the country. So they have national coverage and they really understand their local landscape. So if we're talking about early stage innovations that you need to want to test within an NHS setting, then that's your sort of front door into trying to get to that point. And if you're a digital innovator that is a bit more established, the frameworks that currently exist for procurement, again, are there for a reason, because we know these are technologies that have worked and can work within the NHS and NHS settings, and give providers a bit of reassurance around being able to procure them. So recognise that there is red tape there, but that's for a reason, and those reasons are really around patient and clinical safety.
Yeah. That's really interesting, and you've really picked up a lot of things around funding and around sort of governance issues. Just kind of coming back to that question, there's a bit of a question about capacity. So is there anything in there particularly around ensuring that we can kind of make the best use of workforce in particular to enable some of this digital innovations where possible?
So one of the things that we do nationally, what we used to try to do is we don't just provide funding for the technology, we also provide implementation funding. We recognise, you know, that there are workforce shortages across the NHS, and you know, technology is nothing without the implementation. So providing funding to backfill posts where needed, and also to really push that shared learning element, I think is essential, because you know, where 10 places have done something once and then another 10 places want to do it, they don't have to start, you know, from the beginning. We can give them some of those tools that's actually going to reduce the amount of capacity to implement this technology.
Thank you, thanks. And I'm just going to give a moment if there's anyone else to come in on that question. I think Tracy, would you like to come in on that question as well?
Yes, definitely. As I mentioned initially, we started off our pilot with the intention of using HCAs to take the photographs, and this was a tried and tested format that I had experience of in previous services. Then with the pressures of COVID and vaccine clinics, we started to find that actually HCAs were being pulled from pillar to post and were in very great demand in the practices, and we didn't want to jeopardise the vaccine rollout programme. So we started to look a little bit more laterally, and what we found, actually, we had initially a couple of admin staff who had been working in the dermatology service, very, very experienced at dealing with patients, very experienced at looking at these pictures and downloading them into the notes. And some of them actually had personal interests or hobbies in photography, and asked if they could be involved. We took them through an in-house training program to explain what it was we were looking for, what was important about the image, what, you know, all of those factors that would allow us to do the triage. And they actually started to do clinics, and it was fantastic. The quality of the image was brilliant, and the patients were very happy because these were people who were confident in dealing with them. They weren't there to make a clinical assessment or judgment, which in a way made it easier. The patients weren't too demanding of the photographer wanting to have an explanation on the day, and it just enabled us to continue and expand in what had become really quite a difficult and slightly hostile environment in terms of getting staff and getting dedicated time.
Thanks, Tracy. I think there's a really interesting use there of developing a new area of workforce, particularly around an area where it's taking photos, for example, but also patient facing. On that patient point, I think it'd be good if we can hear from Chris if there is anything you think from the patient perspective around digital innovations and that.
Yeah, certainly. I am involved with the Academic Health Science Network, and I never cease to be amazed at some of the fantastic, innovative project ideas that come our way. We're right to be cautious in the sense that they have to be properly evaluated in terms of the realistic chances of them being implemented. And I always try and make sure that patient benefit is high up on the list. And where, I mean, there have been one or two notable examples, certainly in the last 2 or 3 years, where local innovative suggestions have actually been put into practice with, you know, fantastic patient benefits. I'll just share one quick example from my area, and that was particularly within the pandemic. Very, very sadly, lots of patients were losing their lives in hospitals and ICUs across the area, and transferring those patients in a dignified manner was very difficult and very challenging for staff that were absolutely one off their feet. And a company stepped in with basically a for want of a better word, a portable coffin that could be very quickly used and allowed the patient to be transferred down to the mortuary with dignity. And NHS funded it without any questions. It was implemented within about 2 weeks, and it made a real difference to patients and patient relatives in a very, very difficult circumstances.
Thank you. Thanks for sharing that, Chris. That's really interesting to hear. We've got a few other questions that we're going to bring in, and I'm just conscious of time, so I'm going to try and bring them in one by one. So we've got 2 more questions at least. The first one is around how you support, so linked to the question around workforce that we had earlier, how do you support buy-in from on-the-ground healthcare staff for digital transformation? And we've alluded to that. I know, Tracy, you've mentioned that in your responses earlier. Is there anything else that you wanted to add, or is there anyone else who would like to come in on that question as well?
I don't think I have anything else to add. I think we're covering most of the ground, so.
I'm happy to come in as well on that, because I think to get the buy-in, you have to show what the benefits have been and the benefits for both staff and patients. And I think the more programs we deliver where we start from the beginning to capture the learning from one another. And as I've said before, we weren't prescriptive in how anyone delivered their project. So for some areas, a small project, small steps has been the way to go for the everyone involved on the ground in the primary care settings have been able to see what the benefits are, a small pace that suits them. So the more we share our learning, the more we can share benefits and hear from people like James and Tracy who have implemented different ways of working, and from all the other regions as well. I think we can get the buy-in from that. Yeah. Help towards the buy-in from that as well, and be honest as well. We need to be honest where things have been a challenge and where things haven't worked well, so we've kind of redesigned some of the projects, and that's the whole point of this program, is that we've wanted to learn as we go along, and to be honest and share the learning and share the challenges with one another and bring that all back together across our steering group.
Yeah, that the sharing of learning and information and case studies is a really important point, I think, and something I know that we hear at the fund around all sorts of different areas and topic areas. But thank you, Maxine. If I can bring into the final, the third question that we have from the audience, which is around inequalities. And we've touched upon this as well. We've heard through the various speakers. I guess we've been posed a question as how can we make sure that nobody is left behind? And it's a theme that's emerged in many of the questions. And how do we ensure that the technology is suitable and adopted by disadvantaged groups and other people who are, for example, disabled or people in rural areas and poorer communities and all sorts of groups? I think we have kind of touched upon that, but I think there's a real kind of appetite for a bit more information on that. So if we can if I can go to James first in the first instance, and then I'll bring in Anara.
Yeah, it's something we've thought about a lot in the Black Country. The Black Country is one of the most deprived and certainly one of the most healthcare deprived areas of the UK. We've got a highly ethnically diverse population, lots of population who don't have English as a first language, and quite a lot of uneducated technology poor patients. And that's very much what drove our decision to do a different model of how we run our teledermatology project. We were well aware that our patients, they struggle to get out of the house, they struggle to travel, even to more local hubs to have the photographs done. So we're going down the model of the GPs doing the photographs and the dermoscopic photographs, trying to localize that as much as possible for the patients so they don't have to travel. And if a patient is well enough to seek that initial opinion from the GP, they're well enough to then have to also take all the advantages of having a teledermatology consultation.
Thank you, James. And if I can bring in Anara as well, if you can perhaps the national picture on this.
Yeah, so the sort of position nationally is that digital is an option, it's not the only option, and actually it's not suitable for everyone, and that is the the stance that we do encourage people to take, because we recognise it's not appropriate for everyone, doesn't work for everyone. So I think that's the first point. The second point around there are people that don't have access to mobile phones or data on a regular basis to be able to send these photos, and that's outside the remit of the NHS. But we have, during the pandemic, worked with some of the big telecommunications companies to support more free data for NHS related services, and it's something that we will continue to do. And I think thirdly, the integrated care systems are actually a really good way to start to address digital inclusion, because as I said, you know, this plays out within the NHS, but actually a lot of the digital education that is provided by local authorities, local government, and you know, we need to link up those offers to recognise that people becoming more digitally literate doesn't just, you know, benefit the health world, but it benefits, has much wider societal benefit. So I think this is very much a question of the NHS actually playing a role in what is a much bigger solution.
Thank you, Anara. That's really useful and interesting to hear. I recognise that we've got only about 5 minutes, and I'd like this opportunity to just ask each of the panelists what you would like the audience to take away from this discussion, if just a 1 minute kind of bullet point takeaway message that you'd like to share. I can see Anara on my screen right now, so I'm going to ask you to start and then I'll go round. Thank you.
I think what I'd like the audience to take away is, through this project we've achieved a lot, but there's still a lot further to go. So, you know, what we don't have is national coverage, and actually hopefully what we're able to prove through this work is that technology around teledermatology does have a really big impact for patients and clinicians, and we recognise we're at the start of the journey, certainly not at the end of it.
Thank you, Anara. Next on my screen is Chris, if I can bring you in, please.
Yeah, sure. Very much related to what Anara's just said. For me and my involvement in this programme, I'm absolutely convinced that the patient benefits arising from this are immense. And I really do look forward to everyone supporting rolling this out nationally across the country, because it's very urgently needed.
Thank you, Chris. And just next on my screen is James, if I can bring you in now.
I just said that teledermatology is now proven. There's good evidence out there. The model works, but there isn't a one-size-fits-all model. Tracy's got one model, I've got a slightly different one, and there are numerous other ones. And it all depends on the geography, the locality, on so many factors. And we just need to learn from each other and learn what will work best in our individual healthcare systems.
Thank you, James. And if I can bring in Tracy next, please.
I think my message, I echo everything that has been said, but there's an awful lot of pressure from patients to have face-to-face appointments, and there is quite a well-established belief that that is the gold standard. I genuinely do not believe that teledermatology is a second-class option. I think, in fact, it enables a first-class delivery of healthcare much more rapidly and efficiently for the majority of patients. But as James says, there always also have to be the other options there on the table. But if we could get across that teledermatology actually is really good news, it's not down costing, it's not doing it on the cheap, it's actually upgrading the service.
Yeah, thank you. Thanks, Tracy. And last but not least, if I can bring in Maxine, please, for any final reflection.
Yeah, I'd say digital transformation is about people. It's about how you support the clinical staff. It's outcomes for patients. It's not just about implementing a technical solution at a certain point in the pathway. It's all about how you do that, you implement that, and for the patient outcomes.
Thank you. Thanks, Maxine. As we kind of come to the end of our session, I'd like to thank the speakers and those watching. Would encourage you to share the link to the event to colleagues who can register, and you can watch the event on demand. So if you've missed it, if people have missed it today, you can always kind of catch up. Please feel free to navigate the feedback option as well in the menu, and we really value your feedback to help us to continually improve these events. And finally, thank you again to our event sponsors, NHS South, Central and West. Thank you, everyone.